But if you don't achieve continence, or if your bladder was too small to even try these procedures, because again, Dr. Gerhardt's data which support that you need a bladder capacity of at least 100 cc's in order to even attempt a continence procedure. So if you never reach that capacity of 100, then you're going to have to somehow start thinking about becoming dry. So what's about becoming dry? Well, you're not going to wear a diaper anymore, but it's going to require surgery. So typically we're going to have a bladder that is fairly small, or sometimes a larger bladder, and some of those bladders will have some type of bladder neck procedure. So they'll either have already had a bladder neck repair, or they'll need a bladder neck repair at the time of the getting dry, or you can even actually just ligate the bladder neck, where you actually just close this off if the bladder is not big enough. So some type of bladder neck procedure. So to be dry, you're going to need a bladder neck procedure. Because again, you can't have an open bladder neck and be dry. So that's either going to be either a Young D's, Ledbetter bladder neck, a Mitchell bladder neck, or bladder neck closure. Then you need a big enough bladder. So if the bladder is too small, then we've got to make it bigger. Okay? And that's with a bladder augmentation. And a bladder augmentation basically involves using some piece of intestine. Typically we use a piece of small intestine. So again, the food will go through the intestine, and we take a piece of intestine, and it's anywhere from about 15 centimeters up to about 25 or 30 centimeters. You can actually take about 60 centimeters before you start to worry about any kind of GI problem. That's in an adult. In a child, it's actually a little bit smaller than that. But we would take this piece of intestine, and we would then rehook up the intestine back together, and then we would have this piece that we're going to then use to make it bigger. And the way we do that is we create a U-shaped of that. So now it's a plate, and then we open up this bladder here. So now we have our bladder open with our new bladder neck build, and then we take that and we put it on as a cap. So then that adds right onto as a cap for that bladder. So we have half bladder and half intestine to make up the bladder capacity. Well, that's great, but these do not void spontaneously. They don't squeeze. So now we have to be able to empty the bladder. So that's going to be some type of catheter tube that we can enter. So it's going to be, you can have an appendicovesicostomy, so APV, or appendicovesicostomy, a Mitrophanoff, so a Mitrophanoff, which is a catheterizable stoma, or what I also just call it is as a catheterizable stoma, castoma. So again, all of these are interchangeable. It just depends on what piece of intestine. Typically we use the appendix if it's available. If it's not available, then we just take another piece of intestine and make a little tube. And basically what we do is we take that little tube and we plug it into the bladder. We build a one-way valve on that little tube, and we hook the other end up to the belly button or just below the belly button so that the catheter can go in every 3 to 4 hours to empty the bladder. And then this is the procedure. Usually you're going to involve reimplantations of the ureters. So we usually have to do ureter surgery or reimplants. So again, these are the procedures that usually are going to require to be dry.